all for being here tonight to join us in this very important discussion about the future of women's health in North Carolina. We know how busy all of you are, so we really appreciate you taking the time to be here. It really shows us how important this issue is to you and to our state. I would also like to take a moment to thank the Stanford Women in Policy Club and the Stanford Health Policy Club for making this event possible. For those of you who aren't familiar with SWP, it provides a forum to discuss and address challenges and opportunities for women in the field of public policy. It also serves as a platform for activities and events like this one to engage the greater community in discussions about gender, family, and women's policy issues. And we are always looking for new members to join, both female and male. So if you're interested in finding out more about our club, please come see me or one of our board members after the event. Y'all can just raise your hands if you want to. Great. And also, if you're particularly interested in the Health Policy Club, I highly suggest looking into it. And the club's mission is to provide a space for members of the Duke community to learn and share ideas about health policy. So also, if you're interested in this group, please see Laura Mortimer after the event. She's right down there. Great. All right, well, moving along to the reason we are all here tonight, to discuss the new abortion regulations that have passed in the state legislature this past year. Thank you all for being here today to help share your expertise and knowledge with us. We really appreciate you taking the time. As you know, this past summer, the North Carolina General Assembly passed Senate Bill 353, and Governor Pat McCrory signed it into law on July 29th. This bill affects women's health in many ways. Most notably, it made several changes to abortion regulations in our state. We are here today to discuss the details of these changes, the impetus for these changes, and the effect these changes will have on women's health in North Carolina. Before we get started, I just wanted to review a few of the key provisions of the law in case you all are not sure about it. NC Senate Bill 353 includes the following main provisions. First, it requires clinics that perform abortion procedures to meet similar standards to those of ambulatory surgical centers. It also allows any healthcare provider to opt out of performing or participating in any abortion procedure if it's against their moral, ethical, or religious beliefs. And third, it eliminates abortion insurance coverage for city, county employees, and bars state residents from paying the coverage through state health exchange plans. Now, abortion is a complicated and controversial issue. So for this reason, we have sought several diverse perspectives for tonight's panel. We are fortunate to have 5 highly respected experts join us tonight to help us better understand Senate Bill 353 and what it means for the future of women's health in North Carolina. I ask you to please hold applause until I've introduced all of the panelists. First, I would like to introduce Representative Alma Adams. Representative Adams represents North Carolina's House District 58 in Greensboro and has served in the NC General Assembly since 1994. Prior to coming to the General Assembly, she served on the Greensboro City Council for 9 years, and she retired from Bennett College in 2012 after 40 years of service in academia, where she was a professor of art. She currently serves on the Appropriation, Education, and Government Committee, where she is vice chair. Next, I would like to introduce Suzanne Buckley. Ms. Buckley is the Executive Director at NARAL Pro-Choice North Carolina. She has over a decade of experience working for reproductive rights and social justice. Ms. Buckley worked as a political organizer for NARAL Pro-Choice America in 2003, working to restart the North Carolina affiliate. She gained additional political and organizing experience running statewide and down-ballot electoral campaigns in Lee County, and served as a legislative aide in the North Carolina office of the governor, before attending UNC Chapel Hill Law School, which we will not leave. Now, I would like to introduce Dr. Haywood Brown. Dr. Brown is a native North Carolinian and serves as a professor and chairman of the Department of Obstetrics and Gynecology at Duke University Medical Center. He is a graduate of NC A&T and attended Wake Forest School of Medicine. Dr. Brown is especially committed to the care of women at high risk for adverse pregnancy outcomes, particularly for those who are disadvantaged. He also served as director of the American Board of Obstetrics and Gynecology. Dr. Brown is the immediate past president of the North Carolina Obstetrical and Gynecological Society and is currently District 4 Chair of ACOG. Next, I would like to introduce a familiar face to many of you, Dr. Elizabeth Ananat. Dr. Ananat is an assistant professor of public policy studies and economics here at Duke University. She received a Bachelor's of Arts in Political Economy and Mathematics at Williams College, a master's degree in Public Policy from the Ford School at the University of Michigan, and a PhD in Economics from MIT. In 2010, she served as Senior Economist for Labor, Education, and Welfare at the White House Council of Economic Advisors. Her research focuses on intergenerational dynamics of poverty and inequality. And last but certainly not least, I would like to introduce a familiar face, Dr. Amy Laura Hall. Dr. Hall joins us from Duke's Divinity School, where she serves as an advisor with the Center for Class, Labor, and Social Sustainability with the Duke Center for Civic Engagement. Previously, Dr. Hall served on the steering committee of Genome Ethics Law and Policy Center, and as a faculty member of the Focus Program of the Institute of Genome Sciences and Policy. Dr. Hall also served on Duke Medical Center Institutional Review Board as an ethics consultant to the VA Center in Durham. She is an ordained elder in the United Methodist Church, and she received her Bachelor's of Art at Emory University and her Master of Divinity and PhD from Yale University. Now, please join me in a warm Duke welcome to our esteemed panelists. Thank you all for being here tonight. We greatly appreciate you being here. Thank you. Before we get started, I just have one quick note on format. I'm going to open up with one general question for all the panelists, and then I'm going to move into individual questions for each panelist, and then we're going to save about 30 to 45 minutes for Q&A for the audience. So please be thinking of questions for our wonderful panelists. Given your area of expertise, what impact do you think NC Senate Bill 353 will have on women's health in North Carolina? We'll start with you, Representative Adams.
Well, first of all, let me thank you for the invitation to be here. It's been certainly a privilege of mine to have served students for 40 years. And so I feel very comfortable and at home here with talking to young people. I've had the privilege of serving in the General Assembly under two administrations, actually. I am a Democrat, and I've served for a considerable amount of time under Democratic leadership and also under Republican leadership. And having had that experience, I will tell you that this is the worst piece of legislation that I've seen in my 11 terms of 21 years in the General Assembly. And I think it sets us back hundreds of years, and I think it's going to do a lot of damage as it relates to women's health in North Carolina. I also believe that the bill was unnecessary, and that hopefully we'll have an opportunity to take some kind of corrective action. But I don't see any good as it relates to women's health coming from this particular piece of legislation. I've always believed that no woman can call herself free who does not own or control her own body. That's not necessarily my saying, but I certainly support and agree with that. So I look forward to the discussion and the questions.
Great, thank you. Ms. Buckley?
Sure. I think there's a number of things that we've already talked about, but I think one of the key pieces of understanding is in the context of what women's health in North Carolina looks like right now. So understanding the current landscape, 90% of North Carolina counties have no abortion provider as of today. So for those of you who grew up here, we have 100 counties in North Carolina. So there's only 10 counties that have a local abortion provider. And so over 57% of women in North Carolina lack access to local abortion care. So that's as it exists today. 1 in 5 women in North Carolina between 15 and 44 are uninsured. thinking about this in the context of what's to come, this law, as Rachel was saying, allows the DHHS to make new rules that govern women's health centers that offer abortion care, but what those rules are and what they will look like are still, and we don't know yet. They're in the process of figuring that out. They're in the process of meeting with people largely behind closed doors to get those rules out. So the impact could be very broad. We know that whatever the impact is, that it's going to impact low-income and rural women disproportionately. So thinking about that 90% of counties going down to 98% of counties or 99% of counties is a very realistic impact, given what we've seen this session. Just very briefly, 367,000 North Carolinians no longer have access to comprehensive health care coverage because they are public and state employees. So for example, if you were an employee in Chapel Hill, you had a comprehensive reproductive health care policy as part of your insurance coverage. But as of July 1st, when this bill went into effect, cities can no longer offer that. So just think about at the same time that we're trying to create a competitive workplace environment, we're limiting what our employers can offer to folks. And that's a pretty significant amount of it. And then one more thing that I will just touch on. She was talking, Rachel was talking a little bit about abortion care coverage on the healthcare exchange. And everyone in North Carolina is prohibited from buying comprehensive health care on the exchange that includes abortion care coverage. So if I want to go out and buy a plan as a small business owner and employer, none of those plans can offer that. So it's not, a lot of people say, well, we don't want public funding, for abortion. This is about what I can do with money that I earn in my compensation. So even if you pay for the insurance with your own money, that's no longer an option for you. I would say the same thing about, the refusal clause, which I think we'll get into. But a lot of the impacts of what that really means are unknown, but we do know that it will disproportionately impact rural and low-income women. Just something to really be thinking about, especially with, there's no public funding from the state. We were talking earlier, there's no state abortion fund anymore. You can't use federal income share, federal money to pay for any type of abortion care. So just really thinking about this, not just what it means for North Carolina women, but as part of the national trend.
Great, thank you very much. Dr. Brown?
Well, let me just tell you a little bit about who I am, because as an obstetrician, gynecologist, I've held two key positions. And the first, of course, when all this was going on, I was immediate past president of the North Carolina Gynecological Society. And we represent about 4,000 OBGYNs in the state of North Carolina. I currently represent the District 4 ACOG, which is our national organization. And of course, the national ACOG represents about 57,000 OBGYNs throughout the country. Our district is one of the largest districts, which includes North and South Carolina, Missouri, West Indies, Georgia, the District of Columbia, and Maryland. So we have a huge district. And so when all of this is going on, obviously we're interacting quite a bit with national ACOG, because things were happening to us at the same time things were happening in Texas. It's interesting that I never thought that we would be worse in Texas, but I do believe that the things that happened with this bill were truly worse in Texas. And that's how it really is about restricting access. It really is about chipping away at women's reproductive rights. Starting with what we were dealing with a couple of years ago with interference with the physician-patient relationship and having women have to view an ultrasound before they would have a procedure, to the point where you have bills that are even more restrictive. And this whole idea of restricting access is by requiring a center to have more restrictive criteria than it does when you go in for liposuction, or when you go in to have a cardiac cath, a mobile cardiac cath. And just think about those two things. A 60-year-old man goes into a little van to have a cardiac cath without having to have any of the requirements that they're asking for a provider. And this is all caged in a concept of where we just want to make sure there's safety and quality. And yet the bill was passed in the middle of the night, tied to a motorcycle safety bill. Now, so that puts us, obviously, we know what this bill is about. We know it's about restricted access. And to put it further in perspective, as this will close almost every single Planned Parenthood, the majority of pregnancy terminations in the state of North Carolina are done in ambulatory sites like Planned Parenthood. So 90+% of that. And so what would that have done? It would have taken those 90% of procedures where those women would have to find another place to have them done, or not have them done at all, which is really what the law is about. So not only is it restricting access, but it's putting, it's forcing facilities to meet requirements of a surgical center for a procedure that has been done as an office outpatient procedure since Roe v. Wade was passed in 1973. So that really is the issue. The main objection that we have, and we'll talk about this more as we get into the whole law, is what it does for the relationship that a clinician has with a patient. And that's one of the biggest objections we have for all of these types of things. That you can't go in. You have to read certain types of things to your patients. You have to show certain types of things to them. The final piece I'll just touch on is what does is insurance. And we'll talk about this more. Medicaid is never paid for pregnancy termination. But what this does, because it's federal funding, what this is saying to a person who decides to go online and get an exchange and pay for it out of their own money that they earn, because it is a program that's legislated, they wouldn't be able to use their own insurance that they've just paid for to have a procedure. Now, that's just not right. And so that's really the issues. And when you consider the fact that 54% of babies in the state of North Carolina are on Medicaid, and then you deal with the rest of uninsured women, if they buy an exchange, they would not be able to use that exchange. And so, what's next? You can't buy your pills with it. You know? Oh, they tried that already. What's next? You can't go in and get Plan B. I can go on and on.
We'll have more time for questions. Dr. Alma?
So I feel a little secure next to folks who've been working specifically on issues of abortion policy in North Carolina for so long. And as a researcher, I'm more used to talking about what we don't know. Because my students know I'm very conservative about what we can say for sure. So the question of how will this impact women's health in North Carolina is something I feel a little less secure than these folks do. But I wanted to take us back to the evidence we have from when the Supreme Court decided Roe v. Wade and what happened when abortion became legal in the United States relative to before when it was illegal. And we do have very good evidence that that access to abortion improves women's ability to invest in themselves and in their families. So we saw after Roe v. Wade, we saw a decrease in infant mortality. We saw a big decrease in the share of the children who were born into poor families, born into single parent families. We saw a decrease in the probability that babies were born below birth weight. And all of these things suggest that individual women are in the best position to decide for themselves whether if the context is right to bring a child into their family. And they have information that no one else can have, and this has had a bigger impact on infant mortality and low birth weight and all these things than our medical interventions have had. This has had a bigger impact on the share of kids born in poor families than a lot of our anti-poverty policies have. Women, this is a policy that empowers women to take care of themselves and their families. And so one thing I think one might expect if abortion became illegal was to see a lot of reversal of this. And I do think that the people who are pushing these bills that we're trying to put clear that that's their eventual goal. Now, I don't think that's what's going to happen in North Carolina based on this bill. And the reason is that the evidence from other states when they have restricted things is that women know exactly how important this is. And women are very resourceful in protecting themselves and their families and do a lot of things to overcome the restrictions that are put in their paths. So they travel to other states. They find ways to get to the place they need to go. But they do, and so I don't think this will have anywhere near the impact on the abortion rate that it would have, that I think that people who passed the bill are hoping that it will have. What it will do is make these abortions later, which makes them riskier. And what it will do is greatly increase the burden on women and make it something that is much more expensive and stressful for them to find a place to go, to arrange transportation, overnight, and all these things on women who are already under a lot of duress at a very short point in their lives, and it will have negative impacts on their families, on their communities, etc. It becomes a very stressful thing. So I don't think it will necessarily achieve what the opponents are hoping for. If what they're hoping for is to avoid abortions, but what they're hoping for is to just control women and make their lives difficult, which is sometimes what I suspect is their actual goal. That it will be successful in that way, so I guess they can be proud of that. So I think that those are all the tools, and they will disproportionately, as Ms. Buckley said, disproportionately impact rural and poor women who are a group of women who are already struggling, especially in the state. They're being hit by a lot of things, other things in the state, which is why I tend to think that, in fact, a lot of the motivation behind this is actually to make poor women's lives more difficult, because that's sort of consistent with the other bills that were passed. The one thing I'll say is that it absolutely is not, it drives me nuts that this notion that this is about making things safer, because as you said, this is something that's been done safely in doctor's offices for years. When you're talking about a woman who is pregnant, the safest thing in the world for her to do is have an abortion, because out of 1 million abortions, 1.4 women will die from it, because you can't get an infection from any sort of surgery, etc. Out of 1 million births, 1,500 women. So the notion that this is somehow protecting women's health, as opposed to, giving birth is one of the most dangerous things you can do, even though it's folks like Dr. Brown have made it much, much safer than it used to be. But it's still a very dangerous thing, and for a woman to take the risk to her body, to her health, to give birth, because the state has stripped her of options, I think is just incredible violence to women, and it's something that in the end, realistically, isn't going to impact middle class and upper class women nearly as much as it's going to impact as it never has, because rich women have always been able to find ways to travel.
Great, thank you, Dr. Montgomery. Okay, and Dr. Hall, your opinion on that?
The divinity professor is going to be the most cynical. I was going to say that I actually am willing to say at this point that while I could make the case that individuals and even groups can be pro-life as a matter of conscience, at this point, I'm willing to just state that I believe the nationwide effort to roll back questions like this, policies, these kinds of bills that are going on across the country, are an attempt to divide and dominate. And they are not bills that are about treasuring the sanctity of each and every human life. They are bills that attempt to further oppress and intimidate people who are living through the Second Great Depression. And as someone who cares very much about women's rights and labor rights, living in North Carolina right now is a challenge. It's been a challenge for a long time around labor rights. You may know, some of you, that North Carolina is 50th. We are 50th, and Duke bears a lot of responsibility, by the way, locally for being anti-union. So we're right in the middle of it. But one of the ways that I am living through this time right now with hope is that if you look at what Dr. Evil, which is my little pet name for the effort, that is ALEC, and I always forget exactly what ALEC stands for, so I just call it Dr. Evil. But if you look at the ways that Dr. Evil is attempting to divide and dominate, you can see where power is. So why is the legislature now targeting even further the right to organize for labor unions? Because working people have power, and there is power in solidarity. Why is it that Dr. Evil is targeting women's power and attempting to divide us from one another, to make us frightened of our own bodies? Because there is power in women's bodies, there is power in our sexuality, there is power in our procreation. So the way I'm looking at how this bill is going to affect women in North Carolina, it is my hope and prayer that what it will do is mobilize women across the usual boundaries of division, so that women who could before look at this issue in individualized ways, so women who are upper middle class, upper class, many people who teach at Duke, who work at RTP or whatever, will now be challenged to see the ways that women's health issues affect working women or women in the state. So it is my hope that this is a moment where women will refuse to be and to lean together. And towards that end, I brought a little show and tell, and it's a really good, critical review article by one of my favorite Marxist feminists, named Suzanne, and she wrote a book against she wrote a review against Lean In. It's one of the best reviews I've ever read of any kind, but she goes through and looks at the ways that Lean In feminism is actually not going to get women where we need to get, and that is together and working together on labor issues, working class women's issues across the usual dividing lines. And so that's my hope and prayer. And I brought copies of it. It's from the Baffler, if you're interested. I brought copies of it. It's called Facebook Feminism, Like It or Not. So that's my hope and prayer, is that there will be solidarity across the usual lines of division for women.
Great, thank you very much, Dr. Hall. For Dr. Evil, are you talking about ALEC, just for the, okay, so for the audience members, I think it's the American Legislative Exchange Council?
Thank you.
Yeah.
My brain is blanking on the exact
That's okay.
label for the acronym.
It's basically a commission that writes laws in the hopes that every state legislature will then copy that law and implement the same law. So
you can see it from Wisconsin to Texas to here. It's yeah.
They've also got the standard ground law.
absolutely, the stand your ground laws, the voter suppression laws, wherever you see the possibility for real populism across racial and class lines to break out. It's one of the reasons why they went after Wisconsin first.
Great. Okay, thank you very much for your initial thoughts and regarding the bill and its implications for health here in North Carolina for women. I'm going to move into our individual questions just to allow for time to get a few to you, and then for Q&A, if you could keep your comments around 2 to 3 minutes, that'd be great. Thank you. I'll start with you, Representative Adams. As an elected official in the NC General Assembly, you have the unique perspective in that you were actually a part of this political debate and had an opportunity to vote on the bill. Can you walk us through the political process of the bill?
Well, let me say that as a General Assembly, we have the opportunity to basically write our own laws. And of course, we make laws for the state, but we also have laws that govern, or rules that govern how we do things in committee, in the chamber, and so forth. Typically, a piece of legislation, once a bill is filed, it's a bill before it becomes anything else. Once it's filed, and typically when it's filed, it's referred to a committee, and it's discussed in that committee. It's debated. It's voted on in the committee, and then it moves from the committee to the floor, and it has to go through each chamber. I sit in the House. We have 120 members. 61 votes are required to pass legislation, but in committee, of course, you would also have the majority. Once that bill leaves the committee, and if it passes out of that committee, typically any piece of legislation that is filed it generally does not come out. I mean, the way you introduce it, we have amendments. You can amend the bill, you can change it, and so forth. And most of the time, that bill goes through some negotiations with the members. They want to change things and so forth. In the case of this, and so the bill then it goes, follows that path. It might be sent to another committee that will have to hear it if it has some legal issues around it and so forth. It might have to go to a judicial committee. But once it leaves the committee, it goes to the floor, it's voted on. So you have an opportunity, if you sit on the committee, to hear the bill there, and then when you're on the floor and it comes to you, you'll be able to debate it. So sometimes you get more than one opportunity to really talk about it. As has already been said, this was, I think, one of the very worst bills that passed, and we had an opportunity to debate it. Sometimes we have a process, and this bill actually found itself through another bill. This bill was held, it was originally started out as, I think, 693. It had another number, and it had another name. And so, but all of it was about abortion laws and restriction and so forth. And finally, in the middle of the night, as the doctor has already said, this bill came through very swiftly on a motorcycle. And that original bill, 693, was dumped into what became Senate Bill 353, and then it came back to us. So when we write these rules so that we can oftentimes obstruct justice and really make things right. And that was the case with this bill. We had more than a majority to actually vote on the bill. The bill passed, and there was a lot of opposition to it from not only inside the General Assembly but outside the General Assembly. And I think sometimes, we prepare rules so that we can do a lot of damage in the end, and that's pretty much what we did, and it's going to really impact us in a very negative way.
Great, thank you very much for walking us through that process. Ms. Buckley, as the Executive Director of NARAL Pro-Choice North Carolina, you work to protect reproductive rights in the state. And you also closely follow any and all abortion bills that are introduced and lobby against those that restrict a woman's access to abortion. While NARAL was opposed to this bill, it has already passed the state legislature. It was already signed by our governor and into law. It's now in the rulemaking process. So what's NARAL's next steps?
Sure. Well, the good news is that laws can be changed. So we have to think about sort of the long-term plan. But we did a poll in March, and 76% of North Carolinians think that reproductive health care decisions should be made between a woman, her family, her doctor, and her faith, and not politicians. So the vast majority of North Carolinians think that this is out of touch and extreme, and I believe that they will vote based on that. We know we have a lot of math issues that are going to prevent us from making the swift change that I'll just speak for myself that we would like to see on our state level and in our General Assembly, but these are laws that can be changed and that can be walked back, and we can't lose sight of that, and we have to stay engaged. For the immediate next steps, the rulemaking process, we've been sort of trying to demystify this and go around and talk to different people about it, but the Department of Health and Human Services, which is part of the executive branch, which is under the governor who broke his campaign promise when he signed this into law, has been charged with making whatever new regulations or restrictions on women's health care centers that they would like to propose. Those rules get proposed and then considered by a committee, they get voted on, and eventually they go back to the General Assembly for the stamp of approval or rejection. So this is a long process. The law has passed, but there's a lot of opportunity for intervention and engagement. So I think the things that we're working on right now behind the scenes is trying to make sure the voices that need to be heard around those tables are heard, that healthcare providers who actually do this work are the ones in conversation with folks at DHHS that are talking about the real life impact on women and on their practice. I think a lot of times this is such a politicized issue that people forget that these laws and policies, and that's a lot of what you all learn about, have to be put into practice. So if it's bad policy, it makes bad medicine. And so having those voices be heard around that table is something we're working hard on. For you all, people who are sitting here, oh my gosh, I can't believe this is happening, what can I do? There's an opportunity for public and written comment throughout this process. So there will be proposed regulations, and they will be asking for people to weigh in on that. So whether you're someone who is interested in writing what your thoughts and feelings are, or getting up and testifying in committee and putting your name on the record, I mean, we are looking for those voices. We are also organizing. We have a group of 220, I believe, what we're calling our Rapid Response Squad. Folks who, we had 60,000 people go to, not to knock Facebook, but go to our Facebook. Go to our Facebook page like the night that this bill came out. I mean, I was driving home literally from the beach when I got a call from our lobbyist saying, this has happened. We called our folks who went to Facebook, 60,000 people saw that Facebook page, and 600 people showed up the next morning. And the law did proceed, but it proceeded in a different way, and it was changed because of that outpouring. So making sure that they don't get away with it in a lot of ways, right? So this bill has come out, and a lot of people are just saying, oh, it's over, all the clinics are closing, what can we do? There's a lot more opportunity for process, and then there's also the opportunity to, change the discourse and vote and tell people that you reject this, that this isn't the North Carolina in the future that you want. So those are our immediate and then long-term next steps.
Great, thank you very much. Dr. Brown, this isn't the first time that legislative changes have entered the exam room. In your career, what other examples stand out to you most, and what kind of challenges or maybe opportunities have been associated with those changes?
Well, I would tell you that some of the worst laws we have now about this issue is regarding adolescence. And I'll come back to that in just a minute. Because as we chipped away at this particular issue of abortion, starting with 24-hour waiting periods being undone, which we did not have in North Carolina, adolescence and parental notification for something as simple as contraception. Now this, demanding that a doctor read a script, say a certain thing, not even based on evidence, before a woman would have, a procedure like this. But these are the most recent things, or demanding that she have a vaginal ultrasound. A vaginal ultrasound, not just an ultrasound, but a probe in the vagina, so that she can have said that she has seen the fetus's heartbeat and made an informed decision. So these are just recent things about chipping away the laws. I want to go back a little bit, because I'll go back to 1971, at which time that I was just going into college. And Richard Nixon was president. By the way, Richard Nixon went to medical school, went to law school, right? Now, he must be turning over in his grave now, because this man, who was considered very conservative, signed into law Title 10, which gave poor women access to contraception. Roe v. Wade, which came on in '73, as Nixon was being impeached and thrown out, was signed into law by Gerald Ford, another pro-choice Republican person. Our governor he literally could have vetoed it. At least if he really thought, if he really felt the way we thought that he should feel about this, even though the legislature may have overridden the veto, he could have taken a stand knowing what public opinion was and vetoed it. If you believe that 70% of people believe that women should have their right to make their decisions with their doctors in their own way. So these are the kind of things that are happening with this, but one of the most significant things I will tell you about what this has done is what is an emancipated minor. We have strict laws in the state of North Carolina about emancipation, which is very different than they were in Indiana, where I was. If you have a child, you emancipate. So we had a situation just recently where a young woman who is, 17? Living, one parent is disabled, one parent is dead. She had lived with her boyfriend and her sister. She has a 9-month-old. She gets pregnant. She wants to have a pregnancy termination. But the way the law is written, we literally had to roll her mother in out of the nursing home almost to get a consent for her to have a procedure. She already has a child. And she lives independently and feeds and takes care of herself, goes to school and works 2 jobs. So when you have those types of legislative interference, just based on some law like that, that's dramatic. And even the laws that have been on the books for some time about what an emancipated minor is. By the way, that law was written probably in about 1900. And when things stay on the books that long, there's some real realities in it. And I will go back a little further and even talk about HIV. And HIV early days, and these are also very interfering laws about having to say you have to say this and have to say that, and so forth and so on. So anyway, and the final bill that's really involved, notice that all these involve women for the most part, is the most recent breast density bill. It's where this is a legislative bill. If your patient has dense breasts, and she goes in for a mammogram, you have to tell her that a quote is a higher risk of cancer, even though it really isn't, because there's no evidence of it. Or you increase the cost because the doctor then has to do 2 or 3 different tests. And my final thing that I'm going to say is this, and I know I have to move on. The governor vetoed this with his goal of protecting children. Yet during the government shutdown, he was the only person, the state of North Carolina was the only state that did not allow women to get their WIC, Women's, Infants, and Children's Nutrition Program. Do you care about children? But you don't want to feed them. But we did keep them in this part.
Thank you, Chris. Dr. Ananat, as a research focuses on inequality and poverty. What are the unrecognized effects facing low-income families and communities in accessing reproductive health care?
So in accessing reproductive health care, I want to build off of Dr. Brown's comments and think more broadly than just abortion. I think abortion is a good rallying cry to build bridges across women of all groups, because we can all sort of relate to the threat of, if for whatever reason I found myself pregnant and needed to not have the baby, it's terrifying this thought that I wouldn't be able to have access to an abortion if I needed one. I think, but for low-income women, the things that better off women take for granted about, like birth control pill is very affordable. You can get a generic and it costs $10 a month. That's not a big deal. For low-income women, consistent access to take to birth control, reliable birth control that they can have on a consistent basis is often a bigger issue than access to abortion. Abortion is, you might not need one, and if you need one, it's an emergency event where you can pull from a lot of different resources and probably scrape together to go. And as I said, women understand how vital this is, and for the most part, if they need one, can be very creative and resourceful in finding a way to get that. But the reason that poor women more often need abortions than do richer women is because that $15 a month, is for a lot of women a choice between paying electricity bill and paying for their contraception and access to a provider. Most of our birth control is still prescription. Other countries don't make that choice. Other countries make a lot of these things available over the counter, and they're very safe drugs. But we've made the decision to have these prescription drugs, and it's very unaffordable for poor women to maintain consistent access to abortion, to birth control, to contraception, and this is something that you can imagine is often, I'm not seeing anyone right now. I'll just skip filling my prescription this month, right? And this is a reality of poor women's lives, and they're really making these trade-offs between food, utilities, clothes for their kids, etc., and contraception that get them into the situation where they need abortions more often. And I think that is really is something that richer women often relate to this struggle to get an abortion and don't relate as much to this struggle to get access to contraception that prevents the need for abortion. And so I think actually, as much as I hate this bill, I may be more angry that we're refusing the Medicaid extension. Because if people really want to prevent abortions, what they would do is have the Medicaid extension that, unfortunately, we did manage at the federal level to get rid of this possibility of carving out preventive reproductive health coverage. So women are now, as part of preventive health care, under all the insurance plans, going to have access to subsidized contraception, which has not always been the case, with a few exceptions, but not nearly kind of broad exceptions that they wanted to make. And that's great, but since we're not taking the Medicaid exemption, since we're not taking the Medicaid expansion, and we have a very high poverty rate, we are denying tons of women access to the very thing that would prevent the need for all these abortions, which is another reason why I just think that the claim that this is about women's health or about preventing abortion is laughable. This is about making life harder.
Great, thank you.
Roughly 200,000 women, I figured we wouldn't have.
Who
would be eligible for under Medicaid expansion for healthcare that will not be.
in North Carolina?
Yeah.
Oh yeah, and in the country it's millions. Yeah.
Yeah, right. And if they really cared about children, they would be advocating more spending on public schools and Head Start programs and work protection programs and, yeah.
But that's all stuff that at least it costs the state money to do those things. This is free money.
Right.
From the
No,
federal government.
absolutely.
We just don't want people to have it apparently.
Yeah.
Okay.
We don't want to.
Thank you very much. Dr. Hall, abortion is usually subject to single issue voting. Unfortunately, this is a complicated issue, but it's frequently painted as clear-cut, pro-life, pro-choice. But as women, we recognize that it's usually more nuanced than that. From a Christian ethics perspective, what aspects of the debate are being left out? And how can we engage voters who hold views that fall somewhere in between these polarized stances?
Right, well, it's part of the divide and conquer strategy to use certain wedge issues. Homosexuality is another one, and I'm just going to follow up on a couple comments and then say what I was thinking about saying. So first, I would say as a wedge issue, most people are in the middle, same as with the wedge issue of LGBTQ people and their dignity in the state. Most people in the state are somewhere in the middle in that they're either LGBTQ themselves or they have someone they love very much who is gay, lesbian, transsexual, or queer. There are many people in the state who need to come out as allies around choice issues as well. And so this was part of the effort it's going to be the effort to repeal Amendment 1 is to get people to be out as allies. I think the same thing is going to happen around abortion. People are going to have to speak out from pulpits, from classrooms about why, even if, and in my case, this is the case, as a matter of conscience, I'm pro-life. As a matter of politics, I'm pro-choice. And for people like me, it's crucial for us to be out as allies to the pro-choice movement. And I think there are many people out there who are, as a matter of conscience, wanting to respect the dignity of each and every human life, and do see that in the midst of our current climate, there is a distinct lack of concern about the dignity of each and every human life. And people will speak about that in different ways. I'm speaking from my own conscience at the moment. I would also say, to follow up on Dr. Brown's comments, that there are still residual, even flourishing, small pockets of women's health cooperatives in the state. And I think that there's a need for there to be a resurgence of women's health collectives that are not under the umbrella of any distinguished medical establishment, that are drawing on the wisdom of the Boston Women's Health Collective, lots of other health cooperatives across the country. There's a real need for that. And so that's another hope and prayer in my case. But I will say, in terms of what I see happening, this is kind of complicated, so stick with me for a minute. There are some Christians who believe that sexuality itself is a force for chaos, and who believe that as a force for chaos, sexuality has to be channeled towards a proper end. And that proper end is pregnancy. Some of these Christians believe, not all Christians, and not all pro-life Christians, but some pro-life Christians believe that you can trace other major fissures in Western culture to a lack of sexual accountability, and they trace social chaos then back to abortion. I know this is complicated, but here's then the way it works out. Pregnancy is the due punishment for women having sex. So if women forego that punishment for having sex, there ensues a kind of societal moral chaos. I wrote a very short piece, if you want to Google it, called Pregnancy as Punishment, or When the Pro-Life Movement is Evil, where I try to just it's like 5 paragraphs to name this, but if you know that there's this dynamic going on within some aspects of the pro-life movement, it follows that you would have policies further to punish women who have children out of wedlock, who have not been in various ways considered by these folks to be responsible with their sexuality. So you roll back social programs that would enable such chaotic communities, quote unquote, chaotic sexual, quote unquote, sexual communities, that would, you roll back policies that would enable them to continue in their chaos. So when people wonder, like myself, I wondered for a long time how you could be both pro-life and anti-social welfare, anti-public schools, it's because this child is your mistake for your sexual anarchy. You have to now deal with that mistake. And it's also, you can look at it and tie it in also with those who are pro-death penalty and pro-life, because death is the rightful punishment for the kind of anarchy they see in certain forms of crime. So it's not to say that all within the pro-life movement have that mechanism of thinking, or even that those who have that mechanism of thinking have it in the front of their brain. It's more in their moral gut that sexuality is dangerous and must be channeled towards an end, which is pregnancy, and that thwarting that reduces chaos.
Fascinating. Thank you very much for sharing all of that with us. Thank you, all of you.
What's your book? Where is it?
Great. Well, now we're going to open up questions to all of you.
Can I follow up one thing?
Sure.
Maybe I can get to that question. Because I want to just touch bases on what you just said. Because all you need to do is listen to what Todd Aiken said.
Yeah.
And it ties into the record. If you all don't know, he was running for Senate in Missouri. If she were really raped,
Yep.
the body would shut down and reject the pregnancy.
Yep.
But if she really wanted it,
Yep.
then she got pregnant, and that's her. I mean, that's basically what he was saying.
Yep.
She must have really wanted it because she got pregnant, and therefore her punishment is the fact. But all you need is listen to that, and you understand exactly what we were talking about.
Well, and just to jump on that and how
So as a doctor, you disagree.
Honor is in Western culture, you know, that actually under common law, it was traditionally the case that pregnancy was proof that rape had not occurred. Okay? So a rapist would, you know, you see someone raped if you start showing that clearly you hadn't been raped. That was actually, the charges would be dismissed historically in Western culture. And so this is very deeply rooted and used to be much more explicitly held that pregnancy was a punishment for enjoying sex. Basically. And therefore, as long as you didn't enjoy it, then you wouldn't get pregnant.
My first, if I have to add something, because probably my first session in the 90s when I went to the General Assembly, I was on Health and Human Services. There has not been a lot of discussion about abortion and this issue over like 20 years, but that first couple of years that I was there, I was on the committee, there was a state abortion fund. It was $350,000 in the budget that could be accessed. And the first action in the committee was to get rid of that fund, and so we almost took all of the money out of the abortion fund. And I cautioned my colleagues that we have to be concerned about women who are victims of rape and incest, and that we needed to leave some money in this budget. And finally, the last $50,000, they took all the money out, the last $50,000 was there. And one of my colleagues said that we need to take that money because everybody knows that when a woman is raped, she doesn't get pregnant because the juices don't flow. This was supposedly an intelligent legislator. He was a dentist, as a matter of fact. He was trained.
Oh, my.
But that's exactly what he said. And it was because of that really ignorant comment that money remained, because it just went viral and the press got it, and then it was so embarrassing for his other colleagues that they just dispensed with that debate. But there are people who think like that, and that's what's so unfortunate. And worse than that, a lot of people who think like that have been elected to make policy that impacts all of us in this room.
Your tax dollars working for you.
So, on that note, I hope you have a lot of questions.